Thank you for joining us for this Targeted Oncology Virtual Tumor Board, which is focused on prostate cancer. In today's Targeted Oncology Virtual Tumor Board presentation, my colleagues and I will review 3 clinical cases. We will discuss an individualized approach to treatment for each patient and review key trial data that impacts our decisions. My name is Alicia Morgans, and I'm an associate professor and medical oncologist at Northwestern University's Feinberg School of Medicine in Chicago, Illinois. Today, I'm joined by Dr. Neal Shore, the medical director of the Carolina Urologic Research Center and a urologist at Atlantic Urology Clinics in Myrtle Beach, South Carolina. Dr. Ken Kernan, a partner in the Michigan Institute of Urology PC and the director of research for the Michigan Institute of Urology in West Bloomfield, Michigan. And Dr. Jorge Garcia, an associate professor of medicine and GU medical oncologist at the Cleveland Clinic Lerner College of Medicine and the Kircher Family Chair for Clinical Prostate Cancer Research at the Cleveland Clinic in Cleveland, Ohio. Thank you for joining us. Let's get started with our first case. Dr. Shore?
Great. So thanks, Alicia, Jorge, and Ken. Great to go over this case with you. Let me get into it. It's an interesting case because I think this is really kind of getting to where we are now in new approved indications and new therapies. October 2016, a 64-year-old African-American man, he gets referred to the urology clinic. His PSA is 6.8. Interestingly, his past medical history is notable for having had seizures. He's on anti-epileptic medication. He has a family history that's notable for a mother and sister with breast cancer and a brother with pancreatic cancer. His rectal examination reveals it's essentially normal. There's no nodules or induration. And the urologist here chose, before doing the biopsy, to get a multiparametric MRI. It shows he has an enlarged gland, about 58 cc's. There appears to be a very concerning lesion in the left peripheral zone. It's a PIRADS 4 and 5, and it's about 1.8 centimeter. And there's even a suggestion that there's a seminal vesicle infiltration on one side. He then undergoes the following month a fusion biopsy, and the results are that there are 4 of 12 cores that are positive. And the index lesion, interestingly, has 3 out of 3 cores positive, and the highest Gleason interpretation is a Gleason group 4, or a 4+4. The other cores have 3+4. So he's now ISUP grade group 4. A bone scan and a CT scan are obtained, presumably because of the ISUP4, and they're negative for metastases. His performance status is very good. It's a 0. He then chooses to undergo a robotic assisted prostatectomy with an extended lymph node dissection. And the final pathology shows T3B, nodes are negative, and a further pathological assessment, he's still grade group 4. There is a positive surgical margin at the apex. Patient otherwise does well, and 6 weeks later, his PSA is 0.15. Obviously concerning, it hasn't gone to undetectable. His urologist recommends adjuvant radiation therapy to the prostatic bed. One could potentially argue for pelvic radiation as well for the PT3 disease, but the patient declines to undergo radiation. Don't know all the reasons. Maybe it's because of a desire for sexual function. Maybe it's fear of the toxicity of radiation, but we can certainly talk about that. What's interesting about this case is now the patient is basically saying, I'm going to monitor my PSA. Let's see what happens here. And so several months later, it's July, and the patient has got a PSA of 0.18. And eventually the PSA in the fall, October, is now up to 0.58. By January of 2018, it's 2.8. And then in May the following year, 2018, it's 4.2. Again, a discussion ensues regarding salvage radiation. A restaging scans are done, bone scan, CT scan, presumed full body. are negative for metastases. No other novel next-generation imaging is done at this time. And a decision is made to start the androgen deprivation therapy, and he gets a 6-month depot formulation of leuprolide. The PSA from 4.5 now goes to, a couple of months later, it's down to 1.2. And then from August to October, it's 1.6. And in January of 2019, so we're getting pretty contemporaneous now, is 1.9. Yeah, you know, it's interesting that you'll see there's no real pattern to the regularity of the PSAs, monthly to 3 months to 4 months, which probably is explained by sometimes getting PSAs from their primary care physicians, or maybe we'll talk about what's the strategy, what's the tempo for getting follow-up PSAs. But by April, it's now 2.35, and in July, it's 3.12. And then we come to October 2019, today, as we're presenting this tumor board now, his PSA is 3.81. And for all practical purposes, he is asymptomatic. Obviously, he doesn't have any tumor burden. His imaging is negative. May have some fatigue related to his ADT therapy, may have some hot flashes, may have some loss of libido. And a doubling time is calculated. And his PSA doubling time is 8.6 months. So here we are, he gets restaged again with full body CT, technetium bone scan, and it's negative. So the patient now has an opportunity, given where we are in October 2019, that we now have 3 approved therapies, FDA-approved therapies for the non-metastatic castration-resistant prostate cancer patient, which indeed this is what this gentleman falls into that category, or what in the AUA CRPC guidelines we call index case 1. And prior to 2018, January, we had no level 1 evidence, and now we sort of have, we say this all the time, you know, an embarrassment of riches, but indeed we do. We now have 3 therapies to choose from, and so for this particular patient, he was started on a darolutamide in a BID oral formulation. So, you know, it's kind of a cool case in that, you know, we really couldn't be having this conversation literally a year and a half ago, and now we can have this conversation.